what's happening here is obviously you can see the cardiac silhouette is more than 50 percentage, and there's widening of the carina angle is widened. So this is due to the cardiomegaly, likely since the carina is widened due to left atrial enlargement. In addition, there is a bilateral perihilar haziness that is due to the pulmonary edema, and the pulmonary veins also you can see it's dilated, upper lobe diversion is there. So this is purely due to the mitral regurgitation or left atrial pathology leading to pulmonary edema. In a normal heart, the right heart border is entirely formed by the right atrium, and the left side is by the left ventricle, and over here you can see a left atrial appendage, and this is the aorta. So most of the time in CCU or ICU we are getting the patient, so it's unavoidable to get a AP X-rays. Most of the time we are getting the AP X-rays. So here again cardiomegaly is there. If there's an obvious cardiomegaly, we can say it in AP X-ray. In addition to that, there is bilateral perihilar shadowing due to pulmonary edema. Again, in pulmonary edema, you can identify if you go if you scan through the image in the lateral border, that is along the rib cage, subpleural surface, you can see horizontal lines. Those are called curly B lines. That is due to the fluid accumulation within the alveoli. And this patient from CCU, after a recent myocardial infarction, patient developed SOB. So this is not the normal cardiac contour. There is some bulkiness in the left ventricular region, and you can see some rim-like calcification as well. So this is secondary to the left ventricular aneurysm. Here the heart border silhouette is lost in the left side, and there is some consolidation, airspace opacification, and air bronchogram is there. So patient came with fever, so this is due to the lingual lobe consolidation. So the other thing to assess is we came across trachea, hyla, diaphragms, lungs, all done. So the aorta, it's a opacified area here along the trachea, left to the trachea. The first one is the aortic knuckle, then the descending aorta you can see. Okay, in elderly population, due to the unfolding of the aorta, it can mimic as a mediastinal mass. So we have to check whether it's a continuity from the aorta. So is this normal or not? The aortic contour is there, but here it's disrupted and there's a mediastinal widening. So patient have night sweats and fever, B symptoms. So this is more likely due to the lymphoma. So the same mass we can see in a lateral X-ray over the aorta. So this is the lymph node. So mediastinal mass, again a large subject, so I don't want to go through the entire detail. So we can divide the mediastinum into three: anterior, middle, and the posterior mediastinum. So in a right lateral X-ray, it's easy to identify the area where the heart lie and the hilum, that is called the middle mediastinum. The entire posterior thing is the posterior mediastinum. Anterior to the heart, this is the retrosternal space occupied by the anterior mediastinal mass. But in a PA X-ray, it differs. So we have to go through several signs. There are several signs to detect whether it's where the mediastinal mass is located. First, the mediastinal mass will form a large angle, that is obtuse angle with the mediastinum and an acute angle with the lung. So that's how we are differentiating a lung mass from a mediastinal mass. So anterior mediastinal mass, you can see the hilum very clearly. Again, the posterior mediastinal mass also, you can see the hilum clearly. But the posterior mediastinal mass will go beyond the clavicle. That is one indication of a posterior mediastinal mass. So this is a purely anterior mediastinal mass, which you can see the retrosternal space is obscured, and you can see the hila clearly. And there is no posterior mass in the lateral X-ray. So this is a anterior mediastinal mass. There are four: teratoma, thymoma, terrible lymphoma. Those are the things for the differential for the anterior. Middle mediastinal mass usually arising from the great vessels or through the hila. So the hila, you can't separately see the hila. Hila point is obscure. So hila will be obscure. Any aneurysms, uh, cardiac masses or hila masses can give rise. Posterior mediastinal mass, as I mentioned earlier, it can be along the esophagus or the vertebra. So it will, the lung, hila will be seen clearly, but it can extend to the cervicothoracic region if it is in the upper lobe. Otherwise, we have to go for a lateral X-ray to diagnose. This I explained earlier, I think, this X-ray. So what you see in the abnormality is a patient with SOB when recent surgery, the carinal angle is widened and there are a lot of sutures as well. And ring-like structures are due to the valvular prosthesis. So this might be a mitral stenosis patient who have underwent for valve replacement having left atrial enlargement. Again, apart from the aortic aortic knuckle and the descending aorta, there is an important structure called aortopulmonary window. In between the left pulmonary artery and the aortic knuckle, this window is there. It's usually occupied by the lymph nodes, especially in lymphoma. This space will be obscured. So again, this patient after a thoracic surgery came with severe SOB. You can see the heart contour is lost and you can't see the descending aorta properly. The entire cardiac shadow is replaced by this contour. This is due to the descending thoracic aortic aneurysm. It's a large aneurysm causing distortion of the mediastinum. So, in addition to that, there are several other lines as well. The right paratracheal stripe. Again, it's an important thing for lymphoma. It's a very thin, like 4 millimeter striping area adjacent to the trachea. If it is enlarged, there should be a mass or a lymph node enlargement. Again, esophagus, you can see the esophageal, this is azygoesophageal line is arbitrary line where we assume the esophagus is the path of the esophagus. It's usually from T4 level coming towards left side and go up to the cardioesophageal junction.